Just give me 1 second هلا. Stop this one. بس نبدأ. أولاً مساء الخير لكل اللي موجودين. أنا دكتورة خلود وشاح، أصلاً من قضاء غزة، سكان الأردن، خريجة الجامعة الأردنية، وجيت على أمريكا ب 1992، يعني تقريباً تقريباً 30 سنة. اجينا بس نكمل ريزيدنسي وفيلوشيب، وذاتس هلا صرنا هون تقريبا 30 سنه. عملت الريزيدنسي والفيلوشيب في الكليفلاند كلينيك، واشتغلت فتره ب برايفت براكتس. رجعت هلا على المستشفى اسمه مترو هيلث affiliated مع كيس ويسترن ريزيرف يونيفرسيتي هون عندنا بكليفلاند. وعن جد مثل ما قلت it's an honor إنه نكون نعمل anything to contribute للeducation للresidents أو المedical students بفلسطين. بدي اليوم أحكي شوي على Allergic Rhinoconjuctivitis for more than one reason. First, it gives you a good idea about the allergic reaction in general. Two, it affects a large percent of the population. I am sure in Palestine, it's just like the United States, although most of the numbers, of course, that I have here are from the United States. And then because of the comorbidities that are associated with allergic rhinoconjunctivitis. Allergic rhinoconjunctivitis in the United States, it is a common chronic disease, affects up to 40% of the population, highly associated with asthma, and up to some of the studies say 38% of the population. Uncontrolled, moderate to severe allergic rhinitis strongly affects asthma control. So if we can control the allergic rhinitis, we can control asthma. In addition to the effects of asthma and the usual symptoms that are annoying to the patient, it affects quality of life. Impaired sleep, impaired cognitive function, irritability, fatigue, or decreased school performance. Frequent primary care physician visits are also a big deal with us. The annual direct medical costs. لو حدا بيفكر بقول لك يمكن إنه lost work هون, the lost work, the effect of lost work and productivity from that is more, you would pick maybe asthma to contribute to that, but it's not true. It's actually allergic rhinitis causes more losses annual than does the asthma. And for example, in even the cost of medication or medical treatment, here in the United States, allergic conjunctivitis, best prescription medication, excluding over-the-counter, costs annually about $2 billion just for treatment. لا. لما بتشوفوا هاي السلايد, this slide is representing the IgE-mediated reaction in the body to an allergen. An allergen here can be pollen, indoor allergen, food, drug, insect. كلها رح تمشي بهاي الpathway للend result. The first thing that happens when you are exposed to an allergen on the mucosal surface, when it penetrates, it will be engulfed by the antigen-presenting cell. Antigen-presenting cell examples are macrophages, Langerhans cells. The function of this cell is to break down the allergen, process it, just like its name says, present it on the surface. Now, once it presents it on the surface to the T helper cell that is still not differentiated, this highest cell did not decide to go into a Th1 to help with infections, with a Th2 that will mediate the allergic response. The way the antigen-presenting cell presents it, depending on what MHC class molecule it binds it to, will cause the Th0 cell here to go into a Th2 cell. A T helper 2 cell is the allergy cell. it will produce cytokines such as IL-13 or IL-4. These are important because when they affect the B cell in the presence of these interleukins, the B cell, the sitting normal B cell اللي لسه not stimulated, produces IgM normally. Once exposed to these interleukins, it switches the production from IgM to IgE. The IgE that is produced is not just any IgE. It is IgE specific to the allergen that triggered this whole reaction to happen. Now, this IgE will recognize the allergen on second exposure. The IgE produced will go and sit on the surface of the mastocyte or the mast cell here and just wait for second exposure. هلا لما يصير لنا second exposure, the allergen is going to be bound to the IgE. When it cross-links IgE molecules together, it sends a signal in the mast cells that will activate the mast cell. The mast cell will release the histamine and other mediators, the prostaglandins, and cause all the symptoms that we know in an allergic reaction. So the main mediator that is produced here is the histamine, and that's why we mostly use antihistamines to treat allergic rhinitis. هلا إذا أي حدا بده شيء, please just stop me and ask. We don't have to wait to the end, okay? خاصة مع Zoom meetings, it feels مرات الواحد كأنه there's nobody that they're talking to. هلا الرياكشن اللي شفناه in the allergic reaction, the IgE-mediated allergic reaction, there are two main phases. The early phase reaction, اللي هو immediate response اللي شفناه, which is predominantly mediated by the mast cell. The allergens cross-link the specific IgE on the mast cell surface, بصير عندنا mast cell activation, histamine release, which is the main mediator. هلا histamine we know causes vasodilation, increased vascular permeability, or itching. But if we limit this to the nose and the eyes, this effect, vasodilation is going to cause nasal congestion, or can cause puffy eyes, or edema of the conjunctiva. Increased vascular permeability will cause the runny nose, will postnasal drip, will watery eyes, وبعدين عندنا الitching اللي هم usually the hallmark symptoms اللي بنفكر فيهم when we talk about allergic rhinitis. لا. Late phase reaction, if this reaction continues, بصير في عندنا chemokines or cytokines are released by the mast cell. They attract other cells into the area, usually around 6 hours later. هم eosinophils, basophils, or neutrophils. وهدول they produce their own mediators that cause chronic inflammation. For example, eosinophils produce the leukotriene C4. عشان هيك إذا بتفكروا فيها we use singular اللي هو leukotriene receptor antagonist in the treatment of allergic rhinitis. But keep this in mind so that when we talk about leukotriene, we can say where we use it and when, the leukotriene receptor antagonist. Now, this delayed reaction, a late phase response that happens 6 hours later and causes chronic inflammation, mostly the symptom associated with this phase is chronic nasal congestion. So if we think a little here, the patient can come to us when he's experiencing mostly immediate response or early phase reaction, like the patient who's exposed to a cat, فبكون في عنده sneezing, itching, runny nose, وبكون عنده nasal congestion due to histamine effect. Or we can get a patient who is in the late phase part of the reaction, and that patient is mostly going to have congestion. So keep in mind again, if a patient comes with only symptoms of nasal congestion, does not exclude allergic rhinitis. A lot of people think of allergic rhinitis as just sneezing and itching and runny nose. لازم يكونوا موجودين. They don't always have to be there. Now, there are different classifications of allergic rhinoconjunctivitis. The first one is perennial allergic rhinitis. The symptoms are present all year round, or seasonal, and that's self-explanatory. It's only in the season. Intermittent or persistent. Intermittent allergic rhinitis, less than 4 days per week symptoms, or less than 4 weeks per year. Persistent symptoms are more than 4 days per week or more than 4 weeks per year. The third classification is mild versus moderate to severe. Mild does not interfere with quality of life. Moderate to severe interferes with quality of life. So you can use any of the classifications that you prefer. Hello. I think we talked about this in the early phase. The it's an IgE-mediated inflammatory disease characterized by one or more of the following symptoms, and not all have to be present: sneezing, itching, rhinorrhea, postnasal drip, congestion. In the eyes, itchy, red, watery eyes, blurring of vision, and puffy eyelids. Number 4 in nasal congestion, in allergic rhinitis, it will be bilateral or it alternates sides. Thus, we always have to focus on asking, is it unilateral? If you have unilateral nasal congestion, معناته we have some problem in the anatomy on that side. There could be a deviated nasal septum or even a mass, especially in the older patients. That's important نعرف. مرات كتير المرضى بيجوا بيحكوا إنه مرة على اليمين ومرة على الشمال, بس mostly يمين. That's fine. بس إذا جاني واحد بيحكي لي whatever I do for him, nasal congestion is unilateral, then that patient needs to be seen by ENT. Rhinorrhea is another one to keep in mind. Rhinorrhea can be clear or it can be purulent إذا صار عندنا sinus infection already. But we have to ask about history كمان of trauma, لأنه we've come across some patients with CSF leak, like maybe 2 in the last 10 years or so, not too many, but you don't want to miss the patient who has rhinorrhea from other causes. Now, this, everybody, a very simple diagram, everybody's familiar with it. The frontal sinuses, the ethmoid sinuses, and the maxillary sinuses. And the reason I put this up is we have patients who are referred for evaluation of immune deficiency. And all they have is allergic rhinitis that's uncontrolled. Hello, what happened مع هدول المرضى? We have, when you have chronic allergic rhinitis, you're going to have nasal mucosal edema. And that inferior turbinate usually is huge. The lining also of the rest of the nose is inflamed and boggy, edematous, obstructing the orifice of the maxillary sinus and the other sinuses. With chronic inflammation, too, allows the bacteria or other microorganisms to adhere easily to the mucosal penetrate. So we have increased frequency of sinus infections, chronic sinus infections, and ear infections too, for the same reason, and especially in kids when the ear canal is more horizontal. So these are associated problems that we always ask about in the history. If I treat chronic allergic rhinitis, optimal therapy, and the patient is still getting infections, then I need to evaluate for immune deficiency, and it's usually an antibody deficiency. Now, we talked about the history, the symptoms of the eyes and nose, ear pressure, popping, face pressure, or headaches, history of recurrent and chronic sinus or ear infections. The last thing we have to also ask about is correlation with asthma exacerbations. Because if I have a patient whose asthma is controlled all year until he hits spring, that means that I know what's triggering the patient off is his allergies. So I can start an inhaled corticosteroid in the beginning of the spring or the beginning of fall or whatever triggers him off, and just discontinue it at the end of the spring. And I don't have to put that severe patient diagnosed with severe asthma on an inhaled corticosteroid all year. So this is very helpful in anticipating asthma exacerbations, reducing severe episodes and hospitalizations. The other thing we want to note is the any kind of flare in the eczema too, because we have patients who have absolutely no eczema all year, and then again spring hits. So again, we correlate it with the allergic rhinitis. And these patients, treatments, long-term treatments, such as doing allergy shots, اللي هي subcutaneous allergen immune therapy, will help the allergies and the atopic dermatitis. فهدول بس some things to keep in mind when you are asking the history. Now, physical examination, very easy. نبدأ بالeyes, puffy eyelids, allergic shiners. Allergic shiners are dark circles usually, or darkness under the eyes from venous congestion. The conjunctivae are usually red and edematous, or sometimes you see them very pale, من eosinophils, but red usually due to the increased blood flow. You can see papillae and discharge. The transverse nasal crease, لما تطلعوا على النose on the outside, وهلا بنشوف some images, in nasal salute, هاي من the rubbing of the nose upwards, chronic. If you look in the nose, the mucosa is usually pale or bluish, وفي swelling, and that's mainly the color is mostly due to eosinophil infiltration. But if we already have a superimposed infection, it's going to be red and inflamed. So that does not exclude allergic rhinitis. Hypertrophied turbinates are also common. And we also look in the nose for nasal polyps with septal deviation. The nasal polyps can be seen in patients who have chronic allergic rhinitis, but also you have to keep in mind other reasons such as cystic fibrosis. This image shows the conjunctiva is injected. We see all the blood vessels and the redness on the sclera and in the palpebral or the tarsal conjunctiva. But then if we look too, we see the edema where it's shiny. إذا شايفينها. Do you guys know what I'm talking about? ما بعرف إذا مبين الإيمج عندكم.
Yes, واضحة دكتورة.
شكرا. هلا, this is the transverse nasal crease أو الnasal salute sign, بس إنه chronic rubbing in kids. This is an example of how big the inferior turbinate can be, causing the obstruction. هلا, nasal obstruction, حكينا عن septal deviation, but we also have to keep in mind, some of these patients, after we treat them and they continue to have enlarged adenoids. فهاي كمان we have to keep in mind after we treat, because the intranasal corticosteroids or nasal sprays, the nasal steroids, are very helpful in shrinking the turbinates with nasal mucosa and to some extent any extra swelling للadenoids. But if the baseline is big, it's not going to help. هلا, we got our history and we also did a physical exam, and we think this patient has allergies and we want to confirm our diagnosis. The preferred method of diagnosis طبعا عند كل allergists, we like doing this, اللي هي allergy skin test. but there's also the blood test looking for specific IgE. هلا شو الادvantages للallergy skin test؟ إنه we get rapid results within 15 minutes بعد البليسمنت. The allergen apply, what we do, إنه we take the patient, let me show you the next slide. This is the tray that we use. If you look on the top, these or on the bottom, خلينا نشوف on the bottom level, the lower half of row 2, for example. The bottom half has the well where we put the liquid. For example, the first one can have cat, the second one can have olive tree allergen. Now, above the middle, you see that tip. That tip is a disposable piece of plastic that goes into the well of liquid, and it looks like this. If you look at the middle plastic one is the one that's most commonly used, whether I use it here, and I used it في عمان when I worked there for 2 years. The tip here, it's called a pick. The bottom is a little sharp, and we dip it into the liquid. We take it out, and the patient has numbers on the back so we know where everything is. All we do with it is a tiny prick in the skin to introduce a minute amount of liquid into the skin. Why did we do that? Because we're looking for allergies. So let's say I put 10 allergens on the back, and the patient is only allergic to 3 of them. What's going to happen is wherever there are mast cells that have the IgE specific to, for example, olive, they will recognize it, bind it, and the mast cell in the skin will produce histamine. And then you will get your wheal flare reaction after 15 minutes. If somebody is not allergic, there is nothing to bind, and so nothing will happen. But this is an example of what the back of a miserable allergy patient looks like. If you see, he reacted to almost everything on the back. What we're looking for is the patient needs to have a wheal, اللي هو swelling in the middle, and then the flare reaction, the redness around it. Excuse me. Now, this wheal and flare reaction, the patient has first, we have to have clear skin to do the reaction. We have to have a patient who can stop his antihistamines. لأنه فكروا فيها, إذا الpatient ماشي على antihistamines, they're going to block the histamine effect that I'm counting on. So there has to be an ability to stop antihistamines, which some patients can't do. Clear skin to be able to do this. So if we can't do this, we go to our second best option or next option, which is the blood test. Oh, I think we're missing one slide about my, okay, 1 second, I'm sorry. It's okay. So the blood test, what we do is we're looking for specific IgE to different allergens. What the lab does, the most common test, is they use a solid phase that has the allergens that we are testing attached to it. They add the patient's blood. If the patient has specific IgE to that allergen, it will bind it. And then they wash off anything extra. And then they add another antibody that they can detect by immunofluorescence or any other way, and they measure it. The problem with the blood test, it's not as sensitive as the skin test, and it takes longer to get the results. We used to wait 1 or 2 weeks to get the results. Now, usually we can get them in about 2 to 3 days, but still the allergy test is the ideal to use. I wanted to touch We were talking about mostly seasonal, I'm sorry. Acute kinds of allergic conjunctivitis. There are two other types that I wanted to touch on. The vernal keratoconjunctivitis. The reason being is that this is most common in the Mediterranean basin. So Palestine, it's very common. Jordan, it's very common. And I used to suffer from this في موسم الزيتون. It was so bad, and I'd have to go to the emergency room. It's seasonal, and it's seen in the spring. And I know in Jordan, we used to know it's mostly due to the olive tree pollen. It affects males more than females. Onset is in the pediatric age group under 10 years of age, and usually it improves during puberty. It's the same. We have increased mast cells, eosinophils, lymphocytes, but it turns into a chronic inflammation where we have predominantly lymphocytes. The itching is very intense to the point it can damage the cornea, and there can be impaired vision with time. It's a type of discharge in this is usually thick, sticky mucoid discharge. بيعمل مرات like a film appearance on the eye. There's severe photophobia, foreign body sensation. The patient says إنه كأنه في رمل بعينه عادة, and blurred vision. When we look at patients here, usually we see a giant papillae عاملين cobblestone appearance, يعني مثل الشوارع زمان اللي مرصوفة, and it's usually involving the upper tarsal conjunctiva, and it happens bilaterally. This is another finding you may see. If you see at the connection, the superior limbus, where the cornea connects to the sclera, we have corner Trentus dots. These are collections of eosinophils that are seen not just in vernal keratoconjunctivitis, but also in other forms of chronic keratoconjunctivitis. هاي البابيllae اللي على الupper eyelid in the conjunctiva, it's the other forms, especially atopic keratoconjunctivitis, you see it on the lower eyelid, more classical. Now, the other form of chronic allergic conjunctivitis is atopic keratoconjunctivitis. This is more common in the adults, and they have history of atopic dermatitis, عادة severe atopic dermatitis. So this is because they have it all year round. It's perennial, chronic and severe itching, tearing, clear mucus discharge, and red eye. It can lead to severe ocular damage, يصير في عندنا corneal scarring, corneal ulcers, and vision loss. When you look at these patients, it's easier to tell who they are because they have chronic atopic dermatitis. So usually the eyelids themselves are cracked, scaling, or lichenified, thickened, and there's flaking. Large papillae are predominantly on the lower tarsal conjunctivae. And this is one to keep an eye out for, and the rubbing starts usually at a younger age. This is keratoconus, and it is also associated with chronic forms of ocular allergy and seen to an atopic keratoconjunctivitis. إذا بتطلعوا على الcornea, it has a cone-shaped shape. With time, ببطل, it's more convex, فالfocusing of light على الretina is impaired, and it leads to severe blurred vision. So we diagnosed our patient with allergic rhinitis or allergic rhinoconjunctivitis. أنا بدي أحكي allergic rhinitis لأنها أسهل و shorter. The first thing in treatment is avoidance. So if somebody has indoor allergies, and I know in our countries there are more and more people keeping cats and dogs in the house. In my days, no. The avoidance, if the pet can be removed, that's the best thing. People who have dust mite allergy, and dust mites cause chronic nasal congestion, and are associated with a lot of sinus infections or ear infections. We get special allergy covers للmattress والpillow for avoidance. A lot more common, you guys are going to face a pollen allergy. So one way of avoidance is to keep the house and the car windows closed. Avoid going outdoors on high pollen count days. The pollen counts are higher in the mornings. Trees love to pollinate early morning, and it's usually, the studies say, up till around 10 a.m. After that, it just starts to go down. So we prefer they go out in the later part of the day. Windy days or dry days are worse. Then the pollen moves more. As soon as they come back in, wash the face at least. If possible, shower to wash off all the pollen. And then before we start treatment, the fee over-the-counter normal saline or saline eye and nose washes, you can wash off the pollen from inside. Those are very effective. هلا نيجي للtherapeutic or medical management of the allergic rhinitis. Before I go on, does anybody have questions? Okay, so number one, اللي الكل بيستعملوا is oral antihistamines. They are H1 receptor antagonists, and it makes sense إنه نستعمل antihistamines because the main mediator is histamine. They are H1 receptor antagonists. There are two generations. The first generation, everybody knows it, diphenhydramine اللي هو البنadryl, hydroxyzine, Atarax, for example. They cross the blood-brain barrier, and they are associated with sedation, drowsiness, impaired performance, or anticholinergic symptoms. هلا, you have the patient اللي argues with you and says, oh, أنا باخد البنadryl وما بنعس. That's true, but the studies say almost all patients will have impaired reflex time performance. If he's driving, that patient, the response time is usually slower. So we don't want these patients to use first generation antihistamines, especially that we have an alternative. We have the second generation ones, loratadine, cetirizine, fexofenadine, levocetirizine. They do not cross the blood-brain barrier, and so they are preferred. Halla. Although this is the most common, what almost everybody's on, well, I think in this, you have the same commercial names, Claritin with Zyrtec, with Allegra. We don't prefer them because oral antihistamines are going to be absorbed, will circulate, and some will get to the eyes and the nose, so not a very high tissue level. We have the problem in the eyes and the nose, so why not use an intranasal antihistamine and get a high tissue level in the nose where the patient really needs it? There are two kinds of intranasal antihistamine sprays, azilastine and oloptadine. Both of them are given twice daily. There is one form of azilastine that can be given once daily, but it's more expensive. They are effective as initial treatment for seasonal allergic rhinitis, because in seasonal allergic rhinitis, mostly you have histamine production, and they were found to be effective in non-allergic rhinitis. Non-allergic rhinitis, the patient has the same symptoms of allergic rhinitis, but has a negative skin test and negative blood test. They have faster onset of action. They work very fast, within 15 minutes, whereas we have some of the oral antihistamines that need up to 2 hours to work. They are more helpful for nasal congestion than oral antihistamines. If we want the really effective medication, like with everything else, steroids are the miracle worker. نستعمل intranasal corticosteroids. There are different formulations. I listed some here. If you are asked, or you have to use one medication to treat moderate to severe seasonal allergic rhinitis or chronic allergic rhinitis, or you have a patient who will not use more than one medication, you should pick the intranasal corticosteroid. It will inhibit almost all the mediators, and it also has prophylactic effect. And as long as it's not used over the recommended doses, we don't have side effects with it. Fish and adrenal suppression. When they first came out, they were talking about effects of glaucoma or cataracts, but it was really not proven that in the recommended doses that is a risk. So the ideal therapy in allergic rhinitis, focus on the nose, use an intranasal corticosteroid and an intranasal antihistamine when possible. If you have to use one, use the intranasal corticosteroid. Now, leukotriene receptor antagonists, one example is Singulair or Montelukast, and that is the most common one that is available in the market. We don't like to use it as a single agent. When this first came out, people started using it, and the insurance started to not approve it as a single agent, because if you think back to the slide we had about early and late phase reactions for allergic rhinitis, the leukotriene is more in the late phase, and leukotriene is not a major mediator, so we use it in combination with an oral antihistamine. Singulair, if I remember correctly, came out when I was in my fellowship in the mid-90s, and up to about maybe 15 years, for about 15 or 20 years, the only side effects we would hear about from the patient is some people would say they are tired or they are sleepy when they take the Singulair. But then there were reports of mood changes, suicidal thoughts, and even suicidal attempts on it. So at first, it was thought that this is really not accurate, but then the FDA came out and said, no, this is a legitimate side effect, and you should avoid using it in patients who already have psychiatric issues, and discuss the side effects with your patient. If the patient is on it and develops these symptoms, stops the medication, it is reversible. We also have children who report very bad nightmares. I had one 5-year-old, the parents said that the patient was talking to things that were not in the room. So maybe hallucinations, but we stopped and everything was fine. So avoid it unless you need it. It's helpful in a patient with allergy and asthma because blocking leukotrienes is also helpful in asthma. Systemic steroids. The systemic steroids is not a common practice. Allergists or primary care physicians in the United States used to have their patients come in the beginning of the allergy season, get a long-acting depot kind of injectable steroid that would last them more than 3 weeks. So usually would cover the peak of the season. That's no longer a good practice, we know, because of adrenal suppression and all the other side effects of steroids. So we don't do it. I think I do it maybe once every 3-5 years, and I really have to do it when I do. The other thing is using a short course of the oral steroid like you do for asthma for 3 to 5 days. We only do that in cases that come to us are so severe, we know the antihistamines don't have a chance to work, and the nasal congestion is so severe that the intranasal nose sprays are not going to even get into the nose. Less used medications, intranasal cromolyn, it is the advantage to it, high safety profile, so it's actually safe to be used also in pregnancy. Helpful in seasonal allergic rhinitis. If you know the season the symptoms start, the patient has to start it weeks before exposure. Well, that is the downside or disadvantage for using it. It stabilizes mast cells. It is not very effective for chronic allergic rhinitis. Intranasal ipotropium, اللي هو Atrovent nasal spray, it dries up secretions. So it's useful in perennial allergic rhinitis or non-allergic rhinitis. Is the rhinorrhea is the main symptom. Intranasal decongestants, we don't like them. وبنحكي للمرضى not to use them. And when a patient comes to you and says he doesn't want to use his fluticasone nose spray or Flonase nose spray because he's worried about addiction, this is what he's talking about. They are alpha adrenergic agonists, short. We use them if we have to, short use for up to 5 days, usually 3 days. They are associated with alpha receptor tachyphylaxis. So the patient now needs higher doses and more frequent use to get the effect, اللي هو اسمه rhinitis medicamentosa. And when they stop it, they get rebound congestion. And the rhinitis medicamentosa is not just a long-term effect. It can happen within 3 days of starting the intranasal decongestant. آخر شيء, oral decongestant is pseudoephedrine. We don't like it. In patients with cardiac issues or elderly patients, you guys don't deal with those usually. هلا intraocular antihistamines في عندنا 2 kinds, azelastine وoloptadine اللي هم نفس intranasal antihistamines. They also have, so they're antihistamines بس كمان عندهم mast cell stabilizing effects. هلا, if you have a patient who you have on all those medications, or المريض لسه is miserable, or you have a patient who does not want to take medication, or they have adverse side effects from the medication, we move to desensitizing the patient. Desensitization, there are 2 ways of doing it. The conventional way, which is subcutaneous allergen immune therapy, SLIT, or the newer one, which is sublingual immunotherapy that is available maybe in the last 15 years or so. So subcutaneous immune therapy, the patient gets a lot of injections. The subcutaneous immune therapy, اللي هم allergy shots, is indicated in allergic rhinitis, allergic conjunctivitis, allergic asthma. With a newer addition in the last few years, atopic dermatitis that you can associate with inhalant allergy. And for the patient who only has severe flares, for example, in the spring or the fall, whenever the allergy season is. The patient must have a positive skin test or a blood test that correlates symptoms with his season. Now, we talked about this. We do it in patients who do not respond to allergy medication, the ones who need high dose of medications, experience side effects, or simply a patient wants to get rid of his allergies. How does this work for both subcutaneous and sublingual immune therapy? Once we give these shots, what we do, we don't give a high dose immediately. We do 4 or 5 different dilutions, and we start with the weakest one that can be 10,000 times weaker than the full strength. And we give a small dose, and we increase the dose in that same dilution. The patient has to get a certain number of doses from that dilution, then he can move up to the next level that's 10 times stronger. And again, number of doses in that and moves up. He comes or she comes once a week or twice a week to get the shots until they achieve the highest level and the highest dose. Then they start coming once a month for 5 years. Now, what we are doing, because we are giving small doses in amount and concentration and gradually building up, we are not triggering the IgE pathway. Instead, there's generation of T regulatory cells. The T regulatory cells produce cytokines that inhibit that reaction that we saw in the first slide in this talk. These cytokines are IL-10 or TGF-beta. The IL-10 effects, they decrease the specific IgE production from the B cell. So if I'm giving the patient olive allergen in his injections, the IL-10 interferes with production of IgE specific to olive. It increases the IgG4 production that's specific to olive. Well, IgG4 is a blocking antibody that can interfere with the interaction that we saw again with the B cell with the mast cell and histamine and the IgE on the mast cell. They decrease the cytokines that cause inflammation. So they decrease production from the mast cell with basophils. Well, they induce tolerance. All of this with time results in less response to the allergen that you are giving to the patient. So with time, that Th2 cell profile, a cytokines it produces changes into a Th1 because we're not causing Th2 stimulation. Instead, we have Th1. Initially, there's an increase in the specific IgE levels, but later declines. There also is an increase in IgA, which causes increased IL-10 release from the monocytes. Well, IL-10 shufna what the inhibitory effects are. Hala. Just like we said, each patient has serums that are tailored specific for the patient mixed, and they include what the patient is allergic to. With subcutaneous allergen immune therapy, there is no age restriction on initiating the SCIT. You can do it in toddlers. Our youngest patient is 4, and we have patients who are in their late 70s, one who's 80, I think. They are administered subcutaneously in the MD office. The reason is the patient has a risk of anaphylaxis with each injection, so the patient must be observed for 30 minutes after each injection. Most common side effect is the local reaction at the injection site. That doesn't mean that the patient is not going to have anaphylaxis. So prevalence of the severe systemic reaction, less than 1% in conventional schedules. The conventional schedule is the schedule I told you where the patient comes 1 or 2 times a week. But because there are other accelerated schedules, they're associated with higher risk of systemic reaction. Per year in the US, there are 3.4 deaths per year. And they mostly happen in patients who have poorly controlled asthma. That's why every time these patients come in, we make sure that the asthma is stable. If they are having an asthma exacerbation, of course, the allergy shot is not given. Also, when we are giving a patient his injection in the high pollen season, his system is already being stimulated by inhaling the pollen, and then we go and inject, so we have a higher risk of allergic reaction. Of course, dosing errors, and then new vials. New vials, لأنه لسه it hasn't been on the shelf long enough to lose potency, so with every new vial, we're more cautious. The other form of allergen immune therapy is the sublingual immune therapy. These are tablets that the patient just puts under the tongue, and they have the same effect as subcutaneous immune therapy on the allergy pathway. Approved indications are less than the SCIT. Allergic rhinitis, allergic rhinoconjunctivitis. In the SCIT, we had asthma, atopic dermatitis, in addition to these 2. They still are ongoing studies for atopic dermatitis, food allergies, and others. Contraindications, severe unstable asthma, history of severe systemic reaction to any form of immune therapy, history of severe local reaction to SLIT. ليش? SCIT, we have local reactions at the site of injection are common, but the site of injection is in the upper arms. When we use SLIT, the tablet is under the tongue. So if I have a severe local reaction, it means I had severe swelling of the tongue or the airway. So that's life-threatening in local reaction here. History of eosinophilic esophagitis, because the patient might have this pollen allergy, well, inflammation worsens it. And then medical conditions that increase the risk of fatal reaction if the patient has severe anaphylaxis. For example, patients who have unstable cardiac problems. The SLIT, this is one of the disadvantages. It's available only for dust mites, ragweed, which is a common fall allergy in the United States, and grasses. So we don't have it to trees, we don't have mold, we don't have other allergens. That's why we favor using SCIT more than SLIT. The grass and ragweed, the pollen ones, this is another disadvantage, need to be started 12 weeks before the season. The patient has to remember, or the doctor, to do that. The dust mite, because it's an indoor allergen, you can start it anytime, of course, and you continue therapy all year. Whereas the pollen ones can be discontinued after the season. So the patient can start 12 weeks before the season, and then after the season, they stop them, or they can continue 3 years. Improvement in symptoms and medication scores over placebo were found if you continue for 2 to 3 years after 3 years. Yani, if you treat the patient for 2 to 3 years, and they looked at these patients 3 years after stopping or completing therapy, they still had the same improvement in their symptom and medication scores. They're not using as many medications. With SLIT, the first dose is always administered in the MD office, and the patient is observed for 30 minutes. After that, the patient takes it on his own at home. So that's a disadvantage, that is an advantage over SCIT. But at the same time, you need a reliable patient who can notice if he has an allergic reaction and treat himself. And so we send all these patients home with epinephrine. It's very easy. They put the tablet under their tongue until it dissolves, and they don't swallow, yani we don't to hold for 1 minute, and no food or drink for 5 minutes. The systemic side effects are very rare with it. And like I said, disadvantages, we don't have multiple allergen mixture. Each one is given alone, what's not available for all allergens. We don't have sufficient studies yet comparing the SLIT and the SCIT. And that is the end of this presentation. So if anybody has any questions or wants any clarification, please go ahead.
شكرا لك دكتورة. شكرا على المحاضرة القيمة. معك دكتورة ميساء علاونة، أخصائية الأطفال في مستشفى نجاح. أهلا فيكي. My question about the intranasal steroid in pediatric like fluticasone وميميتازون. إحنا المشكلة عنا لفترة يعني what is written in references about using fluticasone is not safe in children less than 4 years old. فوقتها يعني إحنا جديد حتى الميميتازون intranasal available صار موجود عنا وهلا بنستخدمه لأنه ممكن يكون safer. فلأي عمر ممكن نستخدم الميميتازون؟ لأني أنا شفت يعني immunologists بيستخدموا حتى during the first year of life.
Yes, mometasone is supposed to be safe down to 2 years of age, but we honestly use it even in patients who are less than a year, but we don't do it long term. And we don't have issues, but all we do is explain to the parents, and this is not officially approved for this age, but we need it. The times we use it, Dr. Mesa, is for severe nasal congestion or a patient who has chronic ear infections. But mometasone is safe down to 2 years of age. And we do use it across the board. Hatta flonase, if we have to fluticasone, we use it for patients who are younger than the 4 years of age. Okay. But mostly, like I said, for chronic ear infections.
Yes. What about the intranasal antihistamine? I'm not familiar with this medication. Is it also safe in pediatric?
Intranasal antihistamines are more, again, we use them off-label for younger patients temporarily, but they are mostly approved for patients down to 12 years of age. But extremely, extremely effective. I usually, when I add, you know, here, other than you don't want to, we don't see the side effects, we don't have the concerns about using them at younger age. But of course, even here, especially for America, everything is medical legal. So we usually document that we told the parents that we're using it under the approved age, but temporarily. But extremely, extremely effective because of the high tissue level that you get. And that's what we usually end up doing. A lot of the patients who are referred to us from primary care have been on either oral antihistamine and an intranasal steroid, and not effective. All we do is switch the oral to an intranasal, and all the symptoms basically are gone. كأنه إحنا miracle workers.
That's good. شكرا دكتورة، شكرا.
يعطيك العافية دكتورة خلود. كنت بدي أسأل عن اللوكال ديكونجستنت. It's common عنا إنه نستخدمهم عادة فوق 4 years تقريبا. دكاترة الأنتي ممكن يوصفوهم زي الأوتوريفين والنيرفين. It's common OTC drugs. هي not recommended، بس يعني ممكن تعمل severe rebound symptoms، معروف هاي الحكي. هلا في ريسك في ال other lines of treatment إنه في يصير نفس الشيء severe rebound أو شيء زي هيك أو لا؟
No, دكتورة مي صح؟ We don't have the risk. We don't have the tachyphylaxis. We don't have the main risk, the referrals that we get, again, patients using the OTC, intranasal decongestants, just to get them off. And the way we do it is with the intranasal steroids. We don't see the downregulation of the receptors. We don't see the addiction with those. So we always, the first step is to get them off. But then I think maybe I mentioned it, that the tachyphylaxis, rhinitis medicamentosa, some people think of it as only with really, and when they think chronic use, they're thinking weeks or months. No, what we're looking at is even 3 days. And that's why most people who will use them or allow the patient to use them as a last resource is 3 days, not even 5 days. بدهم مش إنه يتجاوزوا ال 3 days.
Yes, thank you, Dr. Khaloud.
You're welcome. Do you have allergists in the area?
Yes, we have immunologist, allergist, but he's working in outpatient clinic, but not in our hospital.
شو اسمه دكتورة ميسة؟
دكتور عمر أبو زيتون.
عمر أبو زيتون. عمر أبو زيتون كان الدفعة اللي قبلي بالجامعة الأردنية.
Yeah.
إنه عمر اللي أنا.
وهو بيساعدنا والله كثير يعني بعض الحالات بنحول له إياهم، بيعمل بريك سكين تيست إيفن، ويعني بس هو بيشتغل بأوت بيشنت كلينيك يعني، بس مش عندنا بالمستشفى، بس إنه موجود يعني، ويا الله إنه موجود بنفس المدينة اللي إحنا فيها بنابلس.
Immunology هو كمان he's good.
Yes.
دكتور عمر.
Yes. دكتورة خلود، في مجال نعطي إذا في محاضرة في الفيوتشر about أزمة pediatric أزمة.
Of course.
Yeah, we to have such a topic because it's really common.
انتوا هلا أنا اشتغلت بالأردن من 2000 ل 2002 بالجامعة الأردنية، و the main thing was allergy season هو الزيتون، فما بعرف إيش كمان في عندكم غير الإندور allergens.
احنا بنشوف بأوتم يس، هلا بدينا نشوف حالات، وبنشوف بالإيرلي سبرينج كمان، بالسبرينج وقت الربيع ممكن نشوف حالات أكثر شيء.
بتوقع يمكن هلا الأوتم is mostly mold على ورق الشجر والأشياء هاي.
Yes, بس أغلب الحالات يعني ما يكون في definite diagnosis for the antigen causing the allergy يعني.
Yeah. You know, بس عندنا نفس الشيء. Some of these patients what we didn't say ما هو عن allergy skin test كمان. إذا عندك outdoor allergies, it's more effective, or you will get better results with more season exposure. فكل ما مر عليه more seasons بتبين الريزلت على السكن أكتر. You can send a patient إلا إذا عنده already strong allergies or strong family history بيطلع عنا good results on the skin. Other than that ممكن إنه ما يطلع أصلاً results في الأول، يطلع كله negative، بس ال history is allergies والinfections mostly نحن هدول الصغار بيجونا for coughing من ال postnasal drip أو بيجونا because they have chronic infections. فالintranasal steroid عشان هيك بنستعمله even on the younger ones, even just for a short period of time to prove إنه اللي عنا is related to allergy and prevent the infections.
اوكي. ثانك يو. شكرا دكتورة خلود. تسلموا ايديك يا المحاضرة.
عفوا. يعطيكم العافية.
الله يعافيك. شكرا لك.
شكله ما في any more questions. فهيك ما بعرف الدكتور رامي موجود ولا إنه خلص ننهي لحالنا. thank you. شكرا لكم وشكرا كثير إنه أعطيتوني
هالفرصة. دكتورة خلود عن جد محاضرة كثير مفيدة.
الله يعطيكم العافية، وأقل من الواجب بطلعش بإيدنا نعمل إشي تاني، بس أقل من الواجب. أي شيء أنا ببعت الدكتور رامي عنده ماي إيميل، فأي شيء إذا كمان الدكتور عمر مش موجود أو عندكم سؤال أنا مستعدة.
تسلموا ايديك. شكرا كثير دكتورة. إن شاء الله أكيد نتواصل لمواضيع تانية مستقبلا.
يعطيكم العافية والسلام عليكم. مع السلامة.